This is part 3 of chapter 3. And in this part, we're going to start talking about drug distribution. We've been talking about how drugs are absorbed from where they are deposited or where they go into the body and get into the systemic circulation. But now we need to talk about how they get into the tissues where we want them to act. So we're in our second part of the ADME acronym, absorption, distribution, metabolism, and excretion. So we're in the distribution part. And then we're going to talk about the way that drugs exert effects in this particular part of chapter 3. So distribution. Once we get the drug into the systemic circulation, it needs to go to the tissues where we want it to act. Hopefully it goes to that tissue and no other, but the reality is that it will be distributed to a variety of tissues usually. But that's the simple description of distribution. So how do we get from one part of the body to another? So I've been talking about capillaries, and capillary walls are just, in most places, one endothelial cell thick. They are not solid wall pipes, however. They have what we call fenestrations. That's another kind of fancy word for windows. There are these little windows in the capillary walls, and it allows small drug molecules to move freely into the capillaries and then out of the capillaries into the tissues. It does maintain proteins and red blood cells in the capillaries. They stay in, but the smaller molecules are the ones that can pass through. So I have this question here: capillaries, lipophilic or hydrophilic to enter? And in general, that is not something that matters. There's one place where it does matter, but for the most part, capillaries, we do not need to have a drug be either lipophilic or hydrophilic in order for them to pass in and out of the capillary walls. So our exception is the brain. The brain has special capillaries that have tight junctions. And what that means is the cells are tight up against each other. There are no fenestrations. And so in order to enter the brain, a drug needs to be lipophilic. There's other cells, in addition to the tight junctions in the capillary walls. There are other cells that surround the capillaries in the brain. So cells like periocytes, astrocytes, and then also I want to emphasize that there are these little, as we talked about back in the GI tract, and how certain drugs that would cross over into the intestinal mucosa could be kind of thrown back out by P glycoproteins. Those are the active transport pumps that seem to recognize certain types of drugs that it recognizes as toxins. And the same thing happens in the blood-brain barrier for certain drugs. There's an active transport mechanism that may keep even a lipophilic drug molecule out of the brain. But for the most part, the thing that keeps many drugs out of the brain is the blood-brain barrier, the tight fenestrations, and drugs have to be lipophilic to cross it. So you would think that as a survival mechanism that the maternal to fetal circulation would have some protective mechanisms. And while it does have some of the P glycoprotein, the active transport pumps, to kind of reject certain drugs, we can't really count on that. For the most part, the maternal to fetal circulation is an open system, and anything that is in the maternal bloodstream will get into the fetal circulation. So we need to assume that unless we know otherwise, unless the drug manufacturer indicates that something is safe for a pregnant animal, we want to be really careful in what we're giving to pregnant animals. So once we get the drug to the tissue where we want it to go, there is something called tissue perfusion that will make a difference in how that drug gets into that tissue. Just as we've talked about when we place a drug in an active muscle that has good perfusion, that gets it into the systemic circulation pretty fast. The opposite is true about getting it into a tissue. And so if a tissue is well perfused, the drug will get into that tissue a lot easier than if it isn't. So what are well perfused tissues? Think about that for a few seconds. What you would think might be well perfused and what would not be well perfused. So the tissues that we think of as being well perfused are things like very active skeletal muscle, kidney, liver. The brain is fairly well perfused. And on the opposite spectrum, the tissues that are less perfused are muscles that we don't use a whole lot. Do you want to stay away from the back and the legs, but muscles more just on the outside of the torso are not so well perfused. So we typically want to go into, inject into muscles that are well perfused, and we would expect that those would receive drugs being distributed in those areas as well. The tissues that are less perfused are also include fat. Fat does not have a lot of blood vessels in it. We talked about that with absorption, that we don't want to inject things into fat. So it's harder to get drugs into adipose tissue. Some other parts of the body that are less well perfused are things like the globe of the eye. It's hard to get drugs into the globe of the eye. As awful as it sounds, sometimes we have to inject drugs directly into the globe of the eye. Some other tissues are the prostate gland, and then synovial joint areas. Those areas are not as well perfused. So it can be, we sometimes have to inject things into joints if we want it to get there. So we've talked about how drugs will move preferentially into areas that are well perfused more readily than areas that are not. But there's another phenomenon that occurs, and it occurs especially with short-acting anesthetics. And propofol is our example for that. And it's called drug redistribution. What happens in drug redistribution is we put the drug into the bloodstream. So this, I'm talking about IV, injectable, short-acting anesthetics that we inject directly into we inject intravenously. It then goes very readily to the brain. These are typically drugs that are lipophilic, and so they'll go into the brain. The brain is well perfused, so it's pretty easy for them to get in there, and they exert their anesthetic effect. The animal becomes comatose, and then there is also this fat compartment, okay? So some of the drug gets in there too, but it's not as well perfused, so not as much gets in there very fast. Over time, the drug has a redistribution from the brain back into the bloodstream, and then more is taken up in the fat. It tends to stay in there longer. It's not as well perfused. It sort of acts as a little reservoir for the drug. But what's happening is what we're seeing in the patient is less concentration in the brain, so the animal is starting to wake up a little bit. And in the end, when we get a distribution that is relatively equal between the three compartments, we start to get an animal that wakes up. Now, the drug has not been eliminated from the body. It's just been redistributed to another part of the body, and it stays there until it slowly goes back out from the fat tissue into the bloodstream. We need to be aware of this when we are looking at it. Typically, we're using these short-term IV anesthetics like propofol to induce an animal for anesthesia. We're trying to get them sleepy enough that we can, and relaxed enough that we can go ahead and put in an intubation tube and then get them on anesthetic gas to maintain them through a surgery. We need to be careful though with an obese animal, because if we use the dosage based on their weight, a high proportion of that weight is fat. And so we need to give them a dose that's more consistent with a lean animal. So we kind of go on the low end of that dosage. Typically, we're using these drugs to effect, but we just want to be careful in an obese animal because we can give them too much. The drug will reside in the body for a long time, though it'll be redistributed to that to the fat and stay in there, and the animal will stay groggy for a long time. So it's just something to be aware of with these short-acting anesthetics.